Welcome, everyone. We'll give another moment here to make sure that everyone is joined in. Sometimes it takes a minute for folks to connect. All right, so people will continue to come in, but we have a couple moments of introduction before Dr. Ziegler starts. So we'll go ahead and get started. Welcome, everyone. My name is Patrick Sullivan. I'm a faculty member at Emory University in the School of Public Health. Privileged today to co-host this presentation with Dr. Ken Mayer. And today's division of labor is that I'll have the honor to introduce our speaker, and Dr. Mayer will moderate a discussion section after. I would encourage you during the talk to jot down your questions, or you can just message them, to Dr. Mayer. He will be keeping track. So during the discussion section, we'll both call on you, open things up, and you can speak a question, or if you prefer, you can just post the questions in the chat, as Alberto has indicated, and we'll make sure that they get asked. So that's how we'll run the session today. I just have the privilege to introduce a wonderful colleague, Dr. Aaron Ziegler, who's a faculty member at Emory University with over 15 years of experience in HIV prevention research in both domestic and international settings. Aaron received his PhD in 2012, did a postdoc at Emory, and joined the faculty in 2014. Today, he serves as co-director of the Prevention and Implementation Sciences Core in the Emory CFAR. His work focuses on public health impact through implementation science and clinical trials research. He was the PI of a project that developed a national database of PrEP providers. This is a resource that has been accessed by over 1 million users through preplocator.org. So if you didn't already know Aaron's name, which you may well have, you might know preplocator.org. And that was his conception, and he made it a reality. He's led clinical trials that provided data allowing for an FDA 510(k) approval of condoms fitted to penile dimensions, so multi-size condoms available for sale. Thank you, Dr. Ziegler. His current research includes international HIV prevention through technology-based low-touch interventions. He's also led a number of analyses exploring progress in the U.S. scale-up of PrEP, exploring epidemic disparities, and developed the PrEP to need ratio, which we all talk about over coffee every morning. And these data have implications for a number of different policies. So I've had the privilege of working with Aaron for over a decade. So I know from his talk, you're going to see his innovation, his methodologic rigor, his passion for HIV prevention. What is less evident in a scientific presentation, but what I can share with you is the other important things that I know about him as a colleague. And that's his generosity, his kindness, his willingness to mentor and collaborate, and how much he's given to the field by nurturing the professional growth of earlier career colleagues. So for his science and for his mentorship and leadership, it's a privilege to introduce Dr. Aaron Ziegler. Over to you.
Wow. Thanks, Patrick. What a kind and thoughtful introduction. I really appreciate it. I am delighted to be here today with all of you. Thank you for having me. I'm going to be talking about teleprep in the United States and also other large HIV-related claims data sets, and talking about some of the things that my research team has learned over time in looking at these data sets. Um, so quick disclosures, I have no direct financial relationships to disclose to anything related to my presentation. I do lead research grants that have been paid to my institution from Merck, Gilead, and ViiV. Um, so what I'd like to do today is to talk about how teleprep has come to scale in the United States, including some early equity assessments, and think about how we're leveraging large data sets for that work. I'd like to provide a bit of background information about PrEP claims data, how it's obtained and used in the United States, and then provide examples of how national data analyses of large data sets can inform our interventions and public health approach. So wanted to start with just an mHealth framework, how we can think about PrEP and mHealth. There really is a kind of there are numerous levels of what we might call teleprep, and even standard care now, messages from electronic medical record systems and apps that care systems have become almost a standard of care. But you might think about standard of care as often having in-person visits and then in-person lab testing. And then an intermediate level of mHealth teleprep care would involve online visits and messages in between. And then some of that, I think the majority of clinics that we recently assessed for PrEP Locator had in-person local laboratory testing, even with the online visits. Less common, but definitely existing, is home testing. And then a high level of mHealth teleprep would be everything is online. The visits are online, all the labs are online. And then also the online system could really feature messages and interface that optimize and target optimized care, such as reminders and other mechanisms to try to increase retention and care over time. So there really is a pretty wide range of teleprep that we see in practice. What I'm going to be talking about today is really that last option where it's full teleprep, where all the lab testing is optionally done remotely. All the visits are done, including the initiation visit, are done remotely. And so there are these three large national providers or near national providers for one of them, QCare, Mister, and Freddie. And to give you a little background on how these companies operate, two of them have national coverage in all 50 states, Freddie and Mister. Only one of them provides PrEP to people without insurance, and that's Mister. The other two do not provide PrEP to people without insurance coverage, to my understanding. All three of these are for-profit companies, which makes it a bit of a different space than what we're used to thinking about and analyzing data from in public health. So Freddie is a subsidiary of PurposeMed in Canada. Mister is privately owned, and QCare is part of AvidoCare, which is owned by PMQ Investors. So in addition to these larger national or near national companies, there are many, many local and regional level providers of teleprep. I don't think there's a single catalog of these services, but they're numerous and they cover many areas ranging from the county level to multi-state providers that are still kind of regional providers of teleprep care. So in 2025, Mister and Emory began a partnership where we had a limited data set sharing agreement. We did approach other providers. To date, we have not been able to figure out data sharing agreements, although I think we're making some progress. So to be continued. Our collaboration with Mister has allowed for scientific analysis of their data, and we have a number of publications underway and also an NIH grant submission. So Mister Teleprep Care is provided at no out-of-pocket cost to all users, and it also does not turn away uninsured users. So the way this model works is that the company works closely with 65 nonprofit community-based health organizations. Each of these are 340B covered entities. And then the 340B funds are received by covered entities, and these are used in part to contract with Mister. The 340B funds cover all related costs of PrEP care. This includes PrEP medication, doxyPEP, laboratory testing, as well as telemedicine visits themselves. So the key thing here to me is that there's no out-of-pocket cost to all users, which I think is a really interesting model, that the company is able to find enough funds from just the 340B um, program to cover all the components of prep care at no cost to users. And I do think that in the data we'll see, I think that's part of why, likely part of why Mr. has grown so much. So the way Mr. Care works is it's a relatively simple process. Uh, People start with they register with the site. Once somebody's completed their registration, they are asked to complete a brief intake survey. This includes sociodemographic questions, sexual risk factors to inform their PrEP indication, prior testing for HIV and STIs, drug allergy assessments, and also interest in doxyPEP. Then there's a required video telemedicine visit with a clinician that has to be scheduled and then has to be attended. This video visit covers things like how to take PrEP, adverse effects, prescribed regimen options, and then the required laboratory testing. Um, kind of a results review. And the laboratory testing, the users are offered either local in-person laboratory testing or remote laboratory testing. Um, so for the local option, it really refers folks to local labs such as Quests, where they can have a blood draw done, specimen collection done, and then those are tested by local laboratories. Um, and that also is at no cost. Participants can also choose remote laboratory testing. And the remote testing involves a kit mailed to the person's home, specimen self-collection procedure. So there's instructions, person self-collects specimens, and then return mails specimens to a central lab for testing. So our publication kind of describing that care process is available in JAMA Network Open. And what we found was that of 517,000 patients who registered with the website, the majority, 354,800, did not receive a PrEP prescription. And those were for various reasons, and the reasons are not mutually exclusive. So if you add it up, you'll see like these numbers don't add up. It's because they're not perfectly exclusive, but some folks didn't proceed after completing an intake survey. Some did not complete required laboratory tests, and some did not complete the required video call. So those are really the critical components of care that are required to receive care from Mr. And then a small number of persons either tested positive for HIV or had hepatitis B, which Mr. then would refer out to local care. And so of persons who received a prescription, there were 162,422 persons who received a prescription in our study period. And interestingly, the majority of people chose self-collection tests. Just about 132,000 chose self-collection tests, and a smaller proportion chose in-person tests, and then just a couple thousand did some self-collection and some in-person testing. Among the types of medication prescribed among users, 118,000 were prescribed TAF, and 44,000 were prescribed TDF PrEP. And so among those, the majority were generic prescriptions for TDF PrEP. So this is a figure where we look at both the absolute number as well as the proportion of telemedicine PrEP users relative to national. So if you look at the bars, we'll look at the bars first. So the bars represent the number of users. In 2019, there were almost no users. They just started providing services. And by 2022, there were, over 40,000. And by 2024, there were over 110,000 persons using PrEP with this one online teleprep provider. Um, in the blue dots on the with the line is the national proportion of all PrEP users, comparing our data from this to national PrEP estimates from AIDSView, which come from a claims company, IQVIA. And the proportion increases over time. It starts at 0%, but just by 2024, it's nearly 20%. It's like about 19%. So about 1 in 5 PrEP users in the United States is getting is receiving teleprep, and in fact receiving teleprep from a single company. So if, I think given the large number of other the small number of other national providers that we're missing data from, and then also the large number of local and regional providers of teleprep, it's likely a higher proportion than this. So I want to talk a little bit about who these folks are who are using teleprep. So 36% of persons receiving PrEP through this company were uninsured. And that's compared to 8% of people uninsured nationally. So it's a substantially high proportion of people who get PrEP are actually uninsured, likely adding some equity to the receipt of PrEP. Um, of of the users, 79% were not currently taking PrEP. And so that's a pretty similar proportion that also had never taken PrEP. So really, the majority of people accessing care through this model are not dropping out of care from another model and joining. Instead, they're really accessing PrEP, often for the first time, through this model. Um, and so another interesting thing is that 78% of users in the last 6 months reported condomless anal sex. So it's a high risk group of folks, who are probably pretty good candidates for PrEP, are entering this care model. Um, Race ethnicity was similar to national PrEP use. So for this model, 12% of users were Black, 25% Hispanic Latino, 51% white, 7% Asian, and 5% other. For the national AIDSview data, those numbers are 15% Black, 18% Latino, 63% white, and 3% other. So some modest differences, but overall relatively similar proportion. We're not resetting any disparities that we might have seen in national PrEP provision. And I just wanted to remind all of us as we go through this the absolute use relative to the actual need and the disparity between the two. So here are data from AIDSview, and we see that Black persons in the AIDSview data set represent 15% of PrEP users, but 38% of new HIV diagnoses. Hispanic persons represented 18% of PrEP use, but 32% of new HIV diagnoses. And then conversely, white persons represented 63% of PrEP use, but only 24% of new HIV diagnoses. So PrEP is not being distributed in accordance with need, which I also would like to note also means that we're not distributing it in the most efficient manner, that getting PrEP to folks in greatest need also means that we are providing the most efficient control of the epidemic. So there's both a kind of efficiency gains to be had, as well as equity gains to be had in how we address PrEP. And unfortunately, for our teleprep model, pop back for one slide, it's not resetting this. This is relatively similar. Wanted to note that Mr. Has started prescribing DoxyPrep in April 2024. Their total prescriptions just from April 24 to March 2025 were 218,900 prescriptions of doxycycline PrEP. at users. There were 91,000 users who obtained at least one doxyprep prescription out of our total 162,000 users who had at least one PrEP prescription. So doxypep is quite well used by PrEP users in this company's data. So here we looked at the receipt of PrEP prescription. These data are not published. It's kind of an exploratory analysis that we're working on towards a publication on. So here we looked at the receipt of PrEP prescription among people that registered with the provider. And we looked by a number of different variables. Here it's shown by race ethnicity. And so what we see is among Black persons, only 20% or 1 in 5 proceeded to go and get a teleprep prescription after registering with the site. Whereas among Asians and whites, that was 2 in 5. So a literal doubling of the proportion of people who are able to process through from initial registration through to receiving a PrEP prescription. So there's a lot of room for improvement here. You could think about if those levels are more similar, we're talking about an additional, tens of thousands of PrEP users, which would greatly increase equity in the United States by race ethnicity. So then we also looked at this by sex, and we found that it was over 4 times the the proportion of females versus males. So males had over 4 times the level of PrEP prescription receipt follow through of females. And so again, these disparities echo disparities in other literature that we've seen on PrEP equity. So people are falling out of care with this provider in ways that might be addressable. Similarly, we also saw persons with lower education at 20% receiving a PrEP prescription. And here is the largest disparity we observed in terms of absolute number with persons with a bachelor's or master's degree had 50% receipt of PrEP. So half of people with the highest education levels are able to get a PrEP prescription once they register, and just 1 in 5 of people with lower education, high school or less. So a lot of room for improvement here, a lot of disparity that unfortunately seems to echo all of the observed disparities in national PrEP use. So here we looked at retention in and re-engagement of teleprep by a calendar year in initiation. And we looked at different cohorts. Here you see cohorts initiating 2020. There's also a 2021 cohort. And in the publication, we have a 2022 cohort. We'll focus on the 2020 cohort because the numbers are so remarkably similar, regardless of the year. And so among people who initiated in 2020, come 2021, 73% were retained in care and 27% had discontinued. By 2022, 43% were retained in care. A small number reinitiated, 2%, and then 55% discontinued. And by 2023, that raises to almost 2/3 discontinuation, with only 1/3 retained in care. And then by 2024, you're up to 2/3, the full 2/3 of discontinuation, with 27% retained, and then a slightly higher, 5% reinitiated. So really, over time, 2/3 of people are dropping out of care. So pretty substantial retention challenges, which again kind of mirror national PrEP use, maybe slightly better than some of the annualized assessments of non-teleprep care, but again, facing the same challenges with retaining folks long-term in care. And the reason that's so important is that all of our models, every model I've seen shows that the amount of retention and care over time is really critical to control the epidemic because risk occurs over time. So here, this was a master's student, Emilio Lorette de Mola, and he was looking at the probability of PrEP use by past PrEP use quarterly and by a past positive test for an STI. Now, why past positive test for an STI? Folks who previously tested positive for an STI are excellent candidates to be receiving PrEP care and excellent candidates to be retained in PrEP care. It's a specific factor that would indicate somebody for PrEP care in the subsequent quarter. And so what we see looking going forward is the lower two lines of probability represent persons who had a quarter, the previous quarter, they were not in PrEP care. And the top two lines represent persons where the previous quarter they were retained in PrEP care. So we see about a 50% difference in whether a person is on PrEP in the next quarter simply by whether they were on in the previous quarter. Now, interestingly, the STI does have an effect. So the prior STI, the purple group had a positive STI, and the green group had a positive STI relative to the orange, green relative to orange, purple relative to turquoise. And so there's about a 10% bump from having a positive STI to being retained in PrEP, to being on PrEP in the next quarter. And so the story this tells me is that risk definitely plays a factor in how people determine whether they're going to be on PrEP, but even a larger factor than that is simply what they were doing in the last period, whether they were on PrEP or not. And so PrEP is a bit of a sticky variable. Once you lose someone from care, even if they have a factor that would indicate they should definitely be in care on PrEP, they're not very likely to be on it, even given that risk factor. So there's clearly a lot of room to improve, both nationally and in teleprep, on kind of the PrEP equity and also initiation overall, with about 2/3 of person not initiating PrEP in the data set. And then we saw those equitability challenges, but then also there's room to improve in retention and care as well. And so what we have currently proposed with NIH is a multi-stage optimization strategy set of randomized controlled trials. And what this does is it conducts randomized controlled, multiple rounds of randomized controlled testing. And the kind of top line, the AIM 2.1 line, is a surrogate outcome that allows faster measurement. And then later trials, the AIM 2.2 trials, would be health outcomes. And the idea here is that with 110,000 users, you can do a lot of trials. And you can do this almost in a Facebook style, kind of modeling ourselves after the large online businesses that have optimized their outcomes for business purposes. And our concept was to optimize outcomes for public health purposes. And so the hope is that we could have eventually over 60 randomized controlled trials to try to optimize the provision of care within MISTR for equity outcomes and also for overall PrEP initiation and PrEP retention and care outcomes. So kind of a fun and hopefully impactful proposal. We will see. It's in just on time right now, which I'm not sure what that means. It's a new era. So I did want to briefly mention that one of our ongoing projects, the Premise Project, we are assessing many different types of programs that promote PrEP use and PrEP retention and care that are done by state health departments and state funding of county health departments. This work was done in collaboration with NASTAD, and we conducted a survey of state health departments. This covered the years 2016 to 2024. And the survey itself was completed by staff at state health departments, often by multiple staff. It was quite an effort by our supportive health departments. And these data are preliminary and a little old. I think we have 43 or 44 jurisdictions responding now, but the numbers haven't changed too much. So of the answering jurisdictions, 43% had a teleprep program in the time period. Funding came from a real panoply of different mechanisms. So 21 different national and state mechanisms over time funded these teleprep programs. The median expenditure over the pro period was $54,000, but it varied enormously by program, by area. So over $10 million across the jurisdiction in funding was reported for this program type. And we don't view this, I view this as kind of a minimum estimate to just understand. We know that a lot of funding, a lot of funding is missing here, but it just indicates that there has been pretty substantial investment over time in this area. The median operating time for programs is 2.5 years. And some programs are ongoing. So we have underway a kind of causal assessment to understand the impact of teleprep and other programs on overall prep use in jurisdictions and prep equity. So that's underway, but you can really see that the teleprep was really quite an active area of both program and research. And so there's a lot of lessons to be learned, I think, as we continue working in this area. I want to change gears quickly to talk a bit about other types of claims databases for prep. So, in the United States, there's no single entity that collects data on all users of PrEP. And so all of the groups reporting on kind of national PrEP data are using de-identified claims data sets. And they're usually purchased from one of two data aggregators, either IQVIA or Symphony Health, ICON. And this covers the claims capture billing and reimbursement for services. The advantage of these claims data are they have standardized formats. It helps for longitudinal analysis. They have comparability over time and across settings, and they cover diverse healthcare settings. The claims come from clearinghouses, and these clearinghouses, they really are dedicated to converting data from various entities into a standardized transaction for billing purposes. So it allows all the different players, the different insurers, the different pharmacies, and the different hospital systems to all talk to each other in a single language. The claims then go through those clearinghouses. And I think that's where a lot of the data come from, although the data also comes from pharmacy benefit managers and from the hospital systems themselves. So the claims data cover 305 million active patients and 40 billion healthcare transactions annually. So pretty wide coverage, but very notably, claims do not capture data from closed healthcare systems. Prominently among those are Kaiser, which I think is about 8% of people, if I'm recalling correctly. Nationally, they also don't cover persons insured through the VA. So because those companies the Kaiser and also VA, they have internal mechanisms, and so those claims are never going to pass through a clearinghouse. They're not going to pass through a hospital system or a pharmacy benefit manager in a way that gets tracked. Okay. So there's some important decisions to make when we get these claims data. You can either receive aggregated or individual level data. Aggregated data can be used for surveillance and trends analysis. The individual level data are great to understand care trajectories, and they allow for conducting more nuanced analyses, such as related to the impact of policies like teleprep and programs. So either way, the claims data have to be, an algorithm has to be applied to process the data themselves. So you can either develop your own algorithm, which is time consuming, but it forces familiarity with the data set, or you can work with a company that's created their algorithm. So the benefit of doing your own is that it clarifies areas of potential bias. The cost is that it really is quite time consuming. So you're going to pay either way, either from the provider or from researcher time. Um, so the types of data that are available in these claims data sets are quite broad. You For prescription claims, we get medication type, we get quantity filled, we get dates and practitioner de-identified IDs. Um, that's a standard. You get procedures and diagnosis claims for each. You get patient data is exists but sparse, gender, birth year, the first 3 digits of zip codes, and zip codes are old postal routes. And so the first 3 digits sometimes cross state lines. They sometimes extend from Atlanta to Alabama. They have utility and they can be crosswalked, but they are pretty broad. And then you also get you can get state. And then plan data is available. So the name and type, the copay, and the insurer, although that's not always very easy to process, and there's a fair amount of missingness for that. And then additional data options are possible if you, from depending on the provider and the contract, national provider identifiers can be made available, and also race ethnicity can be made available. And so, one lesson that we learned during this process is really understanding very clearly which data have external linking information in your data set and which are internal codes that the data provider themselves use. So, like for instance, one data internal code might be like the pharmacy code, and that will tell you there's one pharmacy that did these prescriptions, but it may not tell you where the pharmacy is or what it means. And so really understanding these data set, which things like national provider identifiers, that is a meaningful external piece of data where you can then look at where the provider is located, their specialty, other information like that. But there are other types of data where they're really internal to the data provider themselves. So race and ethnicity are challenging in these claims data. They're gained from consumer databases that are linked to claims. The data are characterized by high missingness, between a third and 50% missing, depending on the data set. The race and ethnicity data are quite expensive. So for surveillance, AIDSView and CDC use a version of mean imputation, which scales proportions of race ethnicity distributions within jurisdictions. And our team is working with the University of Minnesota on machine learning imputation that leverages a whole data set to determine validity. And this uses a super learner model. So that is on the way. And I think there were some not insubstantial differences between the machine learning model and the mean imputation model. So hopefully we're advancing that a little bit as we go forward, but it's inherently limited in how much of the data are missing. So once you've gotten you're starting to conceptualize what a data set acquisition might look like, we create this framework to help us and other teams understand and kind of conceptualize how you can work with such data sets. So at the bottom, you need domain expertise, specifically in billing structures and coding standards in the US healthcare system. And then once you have that, you can start to really understand and explore the completeness and the quality of the data from the provider. And that might include pharmacy benefit and medical benefit and diagnosis codes. And once you have that, you can develop a scope of work with the contractor, explore your data, clean it, analyze it, and they'll be ready for research. Of note, these claims data have both pharmacy benefit and medical benefit. And you do have to like specifically request both and pay for both. So the pharmacy benefit is predominantly oral prep, although it does include something called white bagging. I'm not going to get into that, but the pharmacy benefit are prescriptions filled at pharmacies, and those use national drug codes. And the medical benefit is predominantly injectable prep. This is prep administered by a clinician in a clinical setting, and those use procedure codes. There are different codes for each of these. And just to show you the complexity very briefly of these types of data. So for our pharmacy data, our data set has 785 national drug codes for HIV antiretroviral medications. Of these, 63 can be used for PrEP. The medical benefit data is simpler. There are only 12 codes, 3 for PrEP. So we see that it really is, it's complex. It's a good challenge if once you get these data to dig in and develop a good algorithm to determine PrEP. So this is our premise grant that covers this kind of work. And our protocol paper has more details on it. It's a really nice collaboration across numerous partners. This is what the data set look like when you get it from the data provider. So there are 13 different categories. These 13 categories each represents a different data set that need to be linked. And then what we did is we were showing in the different colors are the linking variables across the data set. So patient ID is the linking variable, drug ID is the linking variable, diagnosis codes are linking variables, and practitioner IDs are linking variables. And so you link the variables across these different data sets to combine them for analysis purposes. And here's what our algorithm process looked like. We started with 36 million prescription claims, and that we first excluded claims that had triple ARV therapy. We ended up with 22 million claims. We went through a number. I'll let you go through the paper if you're interested. But in the end, we found that there were 13.6 million PrEP prescription claims from 2016 to 2024. And there were 1 million unique patients who had been on PrEP in that period. So although our estimates are, for this time period are closer to annually about 500,000, the total number of people who had ever been on PrEP was 1 million. So about the same number of people have ever stopped PrEP as are currently on it as of 2024, which is, I think, really interesting in terms of how we think about the need to scale up PrEP. Now, CDC recently estimated that 2 million people need PrEP. So either way, we're far short of that. And the types of analyses that can be done, this is an analysis led by Patrick Sullivan, who we all talked to earlier. And here we see PrEP to need disparities by race, ethnicity, and sex over time. And we see how quickly these disparities have grown. Interestingly, proportionally, the disparities have not changed, but the overall number of users has changed. And so the overall level of disparity has increased over time. We see really large disparities by white PrEP relative to HIV diagnoses, by whites relative to Blacks and Hispanics. And then we see very large by males relative to females. And so other types of analyses that we can do with these data, looking at policies. Here we saw on the right that for PrEP prevalence and for the PrEP to need ratio, there were significant increases when PrEP drug assistance programs and Medicaid expansion programs existed in states. Now, this was a cross-sectional analysis, so there are ecological challenges here, and that's something we're working on longitudinally for the next step. And so just a brief from Croy. Here we use the data set to look at injectable PrEP retention and care among 12,000 users. And these are really just cohorts. So for that first year, over half of people were retained in PrEP care for injectable PrEP. But by the end of the second year, only a quarter were retained in injectable PrEP. This paper is in press at JAMA Open and should be coming out soon. It was led by Ernest Coe. And so notably, we did find that Medicaid coverage was higher among injectable PrEP users than oral PrEP users. Same analysis, we looked at the growth of oral PrEP and the growth of cabotegravir, long-acting injectable PrEP from 2022 to 2024. And what we found was that over time, you can see the blue bars on the left are the total number of oral PrEP users. So by 2024, the third triennial period of 2024 had 345,000 oral PrEP users. The same period had 15,000 users of cabotegravir PrEP. So it's about 4% of the overall use of PrEP in this period was injectable. So we see really, really large differences. And one thing to note also, I guess not included in this figure, but echoing other parts of this presentation, is that by race ethnicity, there were not substantial differences between oral PrEP, CAB, and LEN. Um, and here we see oral PrEP, CAB, and LEN, and we see some pretty substantial differences by Medicaid provision and also by copay. Um, Last, I just want to talk a bit about PrEP Locator. And PrEP Locator is a website that we use, that people use to find PrEP. It was launched in 2016. 2025, we're beginning a refresh. I should have updated this last bit. They said we're going to launch in late May, early June. It's now early July. We've been calling over 7,000 clinics nationally, and we're nearly complete with calls. This is what the updated website will look like. The website on the left, the mobile view on the right, and about 90% of our traffic comes from mobile. And what we see here is that the injectable PrEP is a searchable option now. So users will be able to search for clinics that prescribe injectable PrEP. They'll also be able to search for telemedicine PrEP. They'll be able to search for clinics that do same-day oral PrEP starts, clinics that accept walk-ins, clinics that prescribe DoxyPEP, and you can see the other categories. So we hope that these filters will be like a nice new feature. And then we also just updated the overall look and feel of the website, which is, it was getting a little long in the tooth, having been created in 2016. So in conclusion, claims data and teleprep data, like these large data sets, they allow for looking at a national picture of how medication is being used in the US. By combining different sources, these data allow for diverse analyses. But the limitations are they lack contextual data. And so we need to have more nuanced assessments that fill in the gaps that are these large data sets allow us to paint pictures of. So in conclusion, I'd like to thank many, many folks and our funders and so many collaborators that I couldn't possibly begin to list. So thank you all very much. I'm happy to take questions.
Aaron, that was absolutely brilliant. So thank you so much for such an interesting talk and such a creative use of these data sets. Yeah, if people have questions, please put them in the chat. But I have I have a lot of questions for you. So there's 65 organizations that have this partnership with MiSTer with their 340B pricing. I'm just trying to understand the economic model and who are these CBOs, because I would think that in this era of Trump cuts to all kinds of programs that institutions would be kind of jealous of their CBOs and not necessarily outsource to a third party. So I'm just curious how that works.
So I know a little bit about this, but not a great deal. It's something that I've started to look into, but I probably need to have deeper discussions with the company. In my understanding, some of these CBOs are quite directly tied to a foundation that was like it's the Folks Foundation, and I think they share some background with MiSTer. And so that's some of them. I think others of them are more like standalone CBOs that have partnered with. So I don't know the distribution of these two groups, and it's really something I should look more into. But it is interesting that the model. I think the people have been concerned for quite a while. I mean, not for teleprep, but also for all prep provision. That the 340B program is so critical to how prep is prescribed for all the clinics that I know that do it at large scale. It's just a central part of their model because it's such a large source of revenue. And care is very expensive with all these things that may or may not be covered, like the STI testing and it should be covered by insurers, but there's all kinds of gaps and holes. So I think it will be really interesting to see. The encouraging thing is that is that the program is that 340B, I think there are other medications beyond PrEP medications that it relates to. And so that may contribute to the program stability.
Yeah, I think it would be useful to, try to get a sense of the epidemiology of who are the sites, just to, because it's such a large number, but sort of understanding the ecosystem of who's in the tent and who's not in the tent would be useful. So Yanis mentions that Mr.'s, a venture capital company, and I think you had made that point at the very beginning compared to the other platforms. So, but I think, yeah, and I think it would be interesting to know, like, how does what's the epidemiology of who the clients of Mister versus the other two organizations as well.
Yeah, yeah. And I don't understand. I mean, I kind of put in that slide what's publicly available. We do have a survey out to the national teleprep providers. And so that like one has completed it, but the others we're waiting on. And so we'll know more. I mean, the truth is that all of these are privately held companies, right? These are not-for-profit healthcare systems. Um, but I do think it's notable. To me, the most notable part of this is that Mister seems to be the only one that uses the 340B funds to cover uninsured persons, which
Yeah,
I think is the predominant purpose of that program. So they're the only provider that's actually taking that and applying it to allow uninsured people to access the services. So I think that's a good part of their model. I'm sure their model is not perfect, has lots of holes and imperfections, but I do think that's an encouraging part of provision, and that it really is a necessary thing for us to make sure that uninsured people have access to PrEP care in the US.
absolutely. So there's a question from Jessica Haber about how much of the drop off in PrEP reflects people who no longer want PrEP. You know, hard to
Yeah,
get
so
information, but that's true. I mean, some people PrEP may be a bridge, or a transient need.
yeah, absolutely, Jessica. It's a great question. I know it's a long-term interest of yours and kind of a mine too. I think it is interesting when you look at a time period that long, like you've gone out 4 years, it would be interesting to look at risk. One thing we've started to do, I think a relevant data point is the data set published by Kaiser a few years ago. I think it was Julia Marcus published on this. And she found that over 1% of people who discontinued PrEP became HIV positive. I think, and that number was higher than for people who never started PrEP. And we've been looking in our data set, and it's not that dissimilar. We're still working through it because it's a bit messy, but it looks around a percent in our data set as well of people becoming positive, like an annualized assessment of HIV positivity after PrEP discontinuation. So, clearly a lot of people are appropriately getting off PrEP, but there's also clearly a lot of people who may be stopping early. And I will note that it's funny, there's that two-third numbers occurred twice in my presentation. So it occurred first in the like two-thirds register and never get PrEP in the first place. And I think in that instance, those are all people who registered. They said this might be the right thing for me. I'm going to sign up for this website, and then they never got through to PrEP. I think that group probably we should be getting a higher. If somebody's gone through the process of registering for something like this, probably more than a third of them would be good candidates. But it's something for us to look into. Clearly, nationally, we're so far away from targets that trying to convert more folks who might be interested in PrEP is probably the right direction. Then the other place the two-thirds occur in the presentation is in the retention data. And that's where there's kind of this open question, but we do see very high levels of like HIV incidence, at least based on the Kaiser data, and then based on our analyses that support that, but aren't published, and we're still working on it. Very high levels of risk in those populations. So there's a lot to think about in terms of how we can better guide people in when to stay on PrEP and when it's appropriate to get off.
Yeah, I mean the other phenomenon that's hard to track is the frequent flyer phenomenon that maybe having people who are going from one service to another, or going from teleprep to brick and mortar visits. I don't know if thought about that, particularly if people are transitioning from oral to injectables. It may be just as easy just to show up at a clinic, and so then they're counted as attenuation from Mister, but they're actually still engaged in prep care.
That's a good point. Yeah, and in our national analyses where we have the national data, we can look at that. With the MR analyses, the with national all prep analyses, we can look at kind of transitions in care and transitions between formulation types. Um, Harder to do that with the MR data, but definitely um, not published yet, but data that are going to be published. It's a good chunk of injectable prep users are transitioning from oral prep. I'm sure that comes to the surprise of no one, but also a good chunk were new to prep. So it was a healthy mix, I would say.
Interesting. One other thing that really popped out is just the high prevalence of TAF FTC use from the Mister data, and I just wondered if there's any kind of channeling, because clearly, uh, whether it's one of the CBOs or whether it's Mister, they'll realize more income from TAF FTC using 340B pricing.
Yeah, I think that's got to be driving the prescribing, right? I mean, I don't know the data on it, but like I think it drives all the prescribers. It's an analysis we've been thinking about doing for a while, which is like to understand the trends and changes in generics and non-generic prescribing, by insurer type and by other variables. Um, I think that's a big driver, though. It's a big driver. You can't get 340B off generics. You don't get any of that cost return. It's an oddity of our healthcare system, in my opinion. Um, Steph, I see your comment. Thank you for that. And I think you're right to think about how we think about structural and stigma as a part of all of this. I think initially we thought that like, oh, like a lot of the inequities that we see in prep care might be resolved with teleprep because it'll address these stigmas. And that's part of what I wanted to bring to light was like, did it? And to me, the answer is no. It may be starting with getting more uninsured people access to care. Um, but I do think it didn't cause these things to go away. Um, and I do think there's probably a way to start incorporating some stigma metrics and other pieces of data collection into companies like Mister. They have an opportunity to get data on these questions. And I think we've seen this for just ever since PrEP has been around, that stigma has been a major reason that people report getting off of it. And so I think making sure that the appropriate supports are in place is a worthwhile thing, and understanding how that plays a role in teleprep and other areas.
Aaron, just thank you so much for such a brilliant exegesis and just really such a creative way of using a lot of these data to help us sort of understand the unnatural experiments we're undergoing right now as we roll out the different forms of prep. So thank you very much. And thanks everybody for participating. Our next one of these sessions is going to be on August 3rd at noon East Coast time. And thanks everybody for your participation. I want to thank my co-lead, Patrick Sullivan, as well. And again, Aaron, really beautiful job. Thank you.
Thanks, Ken. Yeah, drop me an email, anyone who wants to chat more. Thank you all so much for your time today.
Take care, everyone.